Hello, everybody. I am Tolarova. I am pediatrician and medical geneticist, and I have been involved with children and adults with clefts and other craniofacial anomalies for over 50 years as a clinician in academia and also in research. In addition to taking care of several hundred of patients with clefts in my clinic, I participated in 51 cleft medical missions all over the world with Rotaplus International and also with some other NGOs. I work as professor and executive director of the craniofacial team and cleft prevention program at the University of the Pacific Dugonis School of Dentistry in San Francisco. Among my other responsibilities, I teach 3 quarters course of orofacial clefts and abnormal craniofacial development for residents. I serve as a president of the International Cleft Lip and Palate Foundation that unites over 8,000 specialists involved in treatment and research of orofacial clefts and craniofacial anomalies. My lifelong passion is prevention of cleft lip and palate. In 2015, I founded and I preside a Cleft Prevention International Foundation. This course is designed for non-medical volunteers who are participating in medical missions for surgeries and multidisciplinary treatment of cleft lip and palate with NGOs around the world. For non-medical personnel who are involved in support, help, and fundraising to improve care for individuals affected with cleft and craniofacial anomalies and their families. And also for medical and dental professionals who would like to refresh their overall knowledge about orofacial clefts. How common are clefts? Cleft lip and palate anomalies are second most common birth defects, and for sure, first and most serious congenital anomalies of orofacial region. Let's now look at the world data. Around 140 million babies are born every year in the world. More than 8 million babies worldwide are born with a serious birth defect each year. And what about clefts or another craniofacial anomaly? It is about 200 to 250,000 each year, which means every day it's about 550, 660 each day, and about every hour 23, 25 children born with any kind of cleft. So in average, in every 700 to from 700 to 1,000 newborn, it's born a baby with any kind of cleft. In United States, we have about 7,500 each year born. In India, which has very high prevalence of cleft lip and palate, there is about 36,000 each year born with cleft lip and palate in India. Out of all these birth defects, 35%, which is more than 1/3, are birth defects of craniofacial and orofacial region. And out of these, 80% are cleft lip and palate. What is very important, what I would like you to really remember, that 65% of cleft lip and palate anomalies are non-syndromic cleft lip and palate, and a significant proportion of non-syndromic cleft lip and palate is preventable. There are several types of cleft lip and palate, so it's very important to know how to classify them. The first classification or division of orofacial clefts, it's into non-syndromic ones and syndromic cleft. In non-syndromic, cleft or the cleft lip and palate, cleft palate, atypical facial cleft, or sequences may occur only without any other malformations. In syndromic ones, we may have additional malformation, either in combination, which are well known and defined and classified, then we call them syndromes. Or they can be just together with many other malformations, and then we call them multiple congenital anomalies. As you know, a cleft lip and palate may occur unilateral or bilateral, unilateral or either side, left or right. Left side seems to be more often affected. And then bilateral. Bilateral can be only cleft lip when we can see premaxilla, which is separated and sometimes may be protruding. And then cleft lip and palate, where clefting of the lip and alveolus continues through the midline of the palate. And then we have unilateral or bilateral cleft lip and palate. Atypical cleft, tessier clefts, are very rare, unusual congenital anomalies which actually don't follow embryological development of the clefting, but they have certain types and certain structures, and then very well known plastic surgeon Paul Tessier, French plastic surgeon, divide them on the certain group. What is interesting, the vast majority of these atypical tessier clefts are actually without genetic component. They usually are called by non-genetic factors. Sequences, two sequences are clinically very important for us. It is Pierrot sequence, where we are seeing a baby with very, very small retrognathic mandible. The baby has U-shaped cleft palate, very large cleft palate, a normal tongue, which is actually obstructing airway. And this is very critical for that patient. So sometimes we may postpone cleft palate surgery because that child very often is using cleft for airway. This Pierrot sequence is very, very important to correctly diagnose for all involved, especially for anesthesiologists, surgeons, pediatricians. And another one, rare, but again clinically very significant and serious, is holoprosencephaly sequence. We are seeing missing midline structures or very tiny midline structure. We may see eyes which are close to each other, which will be probably the first sign. We may see very tiny nasal bones. We may see one single upper incisors or missing premaxilla. So whatever is missing in the midline may actually be a very serious sign that something may be not completely correct with development of the brain. Mean that brain hemisphere may not be completely separated. Again, very important, very clinically significant for all involved, all medical personnel involved, anesthesiologists, surgeons, pediatricians, and others. So let's now talk about very important task. These are causes or etiology of cleft lip and palate. Vast majority of congenital anomalies result from the interaction of genetic factors and environmental factors. It's about 1/4, 25%, are those which are caused only by genetic factors, and very small proportion are caused only by environmental factors. The most important part of this, about 65%, are those which are caused by genetic and environmental factors. We call that multifactorial etiology, which means many genetic factors and many environmental factors. And what is important to understand that in this largest group, environmental factors itself or genetic factors cannot cause congenital anomaly. They always must act together. And these are cleft lip and palate, cleft lip, cleft palate, congenital heart defects, neurotube defects, spina bifida, clubfoot, and others. So let's talk now about etiology of cleft lip and palate. As we already mentioned, vast majority of congenital anomalies are caused by an interaction of genetic and environmental factors. And this is exactly the true for non-syndromic cleft lip and palate. Vast majority of those are also caused by genetic factors and environmental factors that must actually act together. If you can look at the chart, these two triangles, pink and green one, you can see that in the middle, largest part, again, we have 65% of those which are caused by genetic and environmental factors. On the right side, when we have these 25%, we may have some of these which are caused only by genetic factors. These are some of these very well-known syndrome, which may have also cleft lip and palate, or cleft palate. And then on the left side, you can see that 10% of those which also may have cleft, but that kind of environmental syndromes may actually be caused only by environmental factors. And you can see, on each of these sides, on the left side with these 10%, yes, we have a little bit of genetics as well, but it's pretty much, just meaning that the different individual with different genotype may actually face that environmental factors. Will be for example, if you have a mother, 10 mothers who were drinking alcohol in same time, same months of the pregnancy or week pregnancy, you will have 10 children born with to those mothers, some of them with very severe fetal alcohol syndrome, some of them completely healthy, and some of them with minimal malformations and minimal kind of symptoms. It means that, that genotype of mother and genotype of the fetus actually act or influence that environmental factors. On that right side, these 25%, again, some of these syndromes may be very severe, some of these syndromes may be very mild, and maybe it is because of different environmental factors were involved somehow during development in utero and influence that severity. However, that 65% in the middle, it's really what is causing a cleft lip and palate, and cleft palate, non-syndromic ones. What I would like you to remember, that if you look at this middle portion, you can see on one side we have much higher proportion of the genetic factors than on the left side, and vice versa. On the left, we have higher proportion of environmental factors compared to the right end of that. So this is really very important for cleft lip and palate patients, and will help us really answer why this happened, how this happened, and when this happened. If you look at the picture of these triplets, these are my patient monozygotic triplets. They have same genotype, okay? And they have different type of cleft, each of them. And again, why this happened? How this happened, and when this happened. And yes, if we understand etiology, we are able to answer these questions. So let's look again in that triangle charts. So we see again the genetic factors and environmental factors. What is very important to understand that these genetic factors, which are forming gene network, are non-modifiable factors. This is what we were born with. These are genes which we have and pretty much, characterize each individual specifically. On the other side, in the green portion of that chart, we see environmental factors, and these are modifiable factors. This is nutrition, this is folate, lifestyle, and so on. And this is again very important in order to understand prevention. We cannot change these genetic factors. We cannot modify them. Well, maybe future research will help with that, but at present they are non-modifiable. But factors environmental are modifiable. We can even exclude these which are not favorable, or maybe modify somehow the lifestyle and nutrition and so on. In these genetic factors are genes which were found to be related of cleft lip and palate. We call them candidate genes. I prefer to call them susceptibility genes because they are making individual susceptible to develop the certain congenital defect. These genes are, for example, those which are related to folate metabolism, which are related to controlling the growth of individual. And this is the list of some of those which we know. For nutrition, among these environmental factors, this is really very important portion of that, because lack of folate, lack of another nutrients, another vitamin may be very serious situation for developing embryo in very specific time. Lifestyle, of course, drugs, and so on. Some of these most important nutrients we actually call candidate nutrients. So let's now plug in this chart our patients with cleft. You will see that on the right side of that middle proportion where we have non-syndromic cleft lip and palate, we have bilateral clefts. On the left side, we have unilateral. What is different? Well, different is proportion of these genetic and environmental factors. And if we will divide them even more, we can see that smaller proportion of non-modifiable genetic factors may have males with unilateral cleft. And then on the other side, on the other end, on the right side, we see that a higher proportion of genetic non-modifiable factors have females with bilateral cleft. And this is very important to understand, specifically for the reason that, yes, we can change or we can modify some of these factors. And if we modify them, genetic factor itself are not able to actually cause clefting. However, where we have better window, we have better window where the window is larger. On unilateral cases, especially in males with unilateral cleft, we have very small window for females with bilateral cleft. That genetics over there, it's very strong. And this is important for two things, for prevention and also for risk of recurrence in the family. Children of our patients with these specific anomalies. So we're learning that understanding etiology is really very important. It's number one, very important for correct and better diagnosis. You can see next to that correct diagnosis star, three types of cleft palate. Different, right? So first one belongs to the patient, which we have on the pictures there. Patient has Pierre-Robin sequence. See small mandible, U-shape, large cleft palate. Okay, So then we see another type of cleft. This type of cleft will be in some syndromic cases. This is a cleft palate which we can see in Apert syndrome. And then finally on the right side, this is the most common type of clefting which we can see either in unilateral or bilateral cases or even in cleft palate alone. So once we have correct diagnosis, yes, we can get better treatment plan. It will be altogether surgical and orthodontic plan and other. And if we will have better treatment plan, we will have, of course, better outcome. And what is again critically important to understand etiology, as we mentioned before, for prevention. Let me stress out 3 P's which we need for the treatment and also for prevention: personalized medicine, precision medicine, and patient-centered medicine. Because each patient is different. If you look at these 4 pictures of cleft lip patients, yeah, each of them has different type of cleft. And we even didn't consider who is male and who is female. So each of these will have different surgical procedure, will have a different orthodontic treatment, may even have different speech pathology approach. And then we have a cleft lip and palate again, bilateral, unilateral, with deviating premaxilla and segment and so. These cleft lips will go under the statistics under the same number. Cleft lip and palate will go again under the same number. But they are different. They are so different that, for example, recurrence risk depends if patient is male or female, if this is unilateral cleft or bilateral cleft, if this is the risk which we are looking for siblings or for children, and if we are looking for boys or girls or sons and daughters. So if you look at these numbers, we can see that, for example, for our patients who is female with bilateral cleft, her risk of having a son with clefting will be 17.24%. And these are real numbers for real pedigrees. Okay, if we look at male with unilateral cleft, okay, his risk for daughter will be much lower, 2.27. So again, combination of sex of the patient and sex of the child or a sibling, it's very important. And that's why we do need to understand to etiology, the different proportion of genetic and environmental factors. Again, this means personalized medicine, precision in description, what is the type of cleft and what is the family history of patient, and patient centers. This patient, it's really the specific, different than other patients, and that's why we need to treat it and look at it like that. Of course, one of the most important tasks is treatment of cleft lip and palate. Vast majority of patients with cleft lip and palate need, and also those which craniofacial and orofacial anomalies need, and disciplinary team care. I like to call this interdisciplinary more than multidisciplinary, because we really need coordinated care of these providers. Many from the medicine, many from the dentistry, speech pathology, genetics, nursing, mental health, and social medicine, and so on. On this very busy chart, you can see timeline of specific procedures, many of these procedures which a child with cleft will go through from the birth until adulthood, pretty much. There are surgical surgical procedure, they are orthodontic procedure, and then all the time, through all that time of treatment, we always need to look at the airway and make assessment of the airway and manage that. This is very important. You can look at this, you can look some of these details. In some centers, it may vary a little bit, but this is most common timeline for specific treatment and procedures for child with cleft lip and palate. Interdisciplinary treatment, it's a gold standard, but not always possible. Again, why I prefer interdisciplinary compared to multidisciplinary. Interdisciplinary means that we are working together at the same time, if possible, at the same time of patient age and consulting the treatment. This is the optimal situation. Sometimes multidisciplinary referrals to specialists during the patient treatment may actually have some gaps in timing, and so again, better is really work together at the same time and discuss a treatment plan. So critical of course is the surgeon. We need cleft lip surgery, we need cleft palate surgery. Minimal requirement will be to have an orthodontist and also speech pathologist and therapist. We would say that sufficient will be including also pediatrician, genericist, or a maxillofacial surgeon. And of course, optimal will have all those 12 specialists which are listed here. Surgeons, an anesthesiologist, orthodontist, speech pathologist, pediatrician, genericist, oromaxillofacial surgeon, ENT specialist, pediatric dentist, psychologist, nurse practitioner, social worker, and genetic counselor as well. Having all these specialists involved and having all these procedures which we listed, which patient with cleft lip and palate will need during the lifetime, means that this is really expensive. Medical costs are high. This is very conservative estimate, which was done by colleagues from business school in Berkeley. It's about 100,000 per one child, only in medical cost. And it's about 1/3. It's during the first year of life for cleft lip and cleft palate surgery. If we look at estimated average lifetime total cost, medical and non-medical, it's about double. It's 200,000 per one child. So if we have 7,500 babies with orofacial cleft, which are born every year in United States, it means that we will need $750 million only for those who are born within 1 year. That's why, of course, prevention is critical even from the point of financial. With improving technology of imaging, more and more often we see the patients who cleft has been diagnosed prenatally. So most common prenatal method to diagnose orofacial clefts is ultrasound. About 90% of cleft lip can be diagnosed in second trimester. Yes, it is possible even at the end of first trimester to diagnose clefting, but it's very difficult and very rare. We have 2D ultrasound, which is pretty much same as X-ray, which we know. You can see on the pictures here, which is the picture, pretty much 2D pictures, like when the child or a fetus in this time, it's putting the nose to the glass. With the tip of the nose, we see both clefted part of the upper the jaw and the lip actually there, and then echo of the chin. And then on the profile, if we are lucky like that, we can see protruding premaxilla. Much better are pictures which are in 3D, which you can see on these pictures on the right side, prenatal diagnosis, and then the picture of the patient after baby is born. So it's much more precise, and even in cases of cleft palate, we are able, it is challenging, but we are able to diagnose cleft palate. Practically impossible is diagnosed to cleft palate on 2D ultrasound. About 60 to 80% of cleft lip and palate, with or without cleft lip, with or without cleft palate, are in the US diagnosed prenatally, which is very good because we can consult the parents and present them treatment plan, and they can be prepared for the child with cleft, not to be shocked with finding. In some more challenging and difficult cases, we may actually use also MRI. We can use amniocentesis and chorionic villus samplings in some syndromes and in some chromosomal aberrations. 4D, 4D ultrasound, it's pretty much movie, which we may use sometimes in providing for parents, and they like this movie. So it's a more and more common in these days. On this picture, you can just see 3 examples of prenatally diagnosed cleft lip. First case is cleft lip and alveolus there, postnatal and then post-surgery. The second one, it's complete cleft lip and palate, unilateral, and the last one, it's actually bilateral complete cleft lip and palate. And finally, my lifelong passion, prevention of cleft lip and palate. We will talk about cleft prevention in more details in separate video, but these are just the most important information which I would like you to learn. We can distinguish 2 types of prevention. Prevention of baby with congenital anomalies to be born, we call that secondary prevention, which is actually not prevention, because we diagnosed the affected fetus prenatally and then we terminate the pregnancy. It may actually be reasonable if some of these life-threatening conditions like anencephaly and similar, but this is still, questionable. Real prevention is before anomaly develops, called this primary prevention, and a very good example is supplementation by folic acid, and also fortification food by folic acid, like cereals, flour, and so on. And then we have 2 categories: occurrences, which will be prevention in general populations, and then recurrences, preventing recurrence of that anomaly in the same family where already a mother or father or a close relative had the same anomaly. We have excellent results from our studies of primary prevention of non-syndromic cleft lip and palate. The first one, prevention of recurrences, which we did study in my home country in Czech Republic. We used large number of individuals, over 200 of those who were at risk of having a child with cleft. And we supplemented them with high dose of folic acid, 10 milligrams of folic acid, and some other multivitamin in periconception period. We were able to decrease recurrences by 65%, from 65 to 82% type, depends on type of the anomaly. And another study we did here in United States on California data supported by March of Dimes, California Birth Defects Monitoring Program. We were looking retrospectively on occurrences of cleft lip and palate. We were looking at supplementation or folic acid in food of mothers, over 700 mothers who had a child with a cleft. They didn't have any history of clefting in the family, and then compare with those which had the child which was without any birth defects. And what we found, that those who had at least 0.4 milligrams, 400 micrograms of folic acid daily in, again, periconception period, they had reduced of risk of having a child with cleft from 27 to 50%. Again, more details I will present you on a special video on cleft prevention. As I was presenting on previous slide, we really achieved very significant success of decreasing of recurrences of clefting, and also with lower dose decreasing of occurrence, first occurrence of clefting, high dose for recurrences, lower dose for occurrences. However, as I mentioned before, we only at present can do prevention in that area, in that part of modifiable factors, which is diet, where will be low folate, low zinc, low B6 vitamin, and also what is the risk is high vitamin E in diet, and also excluding environmental toxin, which will be tobacco, of course, air pollution, pesticides, low social economical status related factors, which will be, mainly nutrients or not enough calories and so, and also household toxins, which may be some chemicals, but also maybe cooking on open fires and similar. Another challenge, the big challenge, is that we have very small, very narrow window during which the phase is developing. On the picture you can see 6 weeks old embryo and 7 weeks. 6 weeks everything is apart, 7 weeks everything is together. If we really would like to change that, there is kind of the, susceptibility for clefting there. We need to target this window in this periconception period. That's why instead of using this exactly during the pregnancy, we need to cover periconception period, before conception, and then first few weeks after conception. How to start cleft prevention? Well, definitely we need more research and more data. However, number one is education. Number one is educate ourselves, educate medical community, dental community, lay public, educate families where cleft occurred, educate individuals who are affected with cleft, awareness building. Okay, they are 3 necessary requirements for healthy embryonic and fetal development: a healthy mother, healthy lifestyle, and healthy nutrition. There are several places where already cleft prevention activities are going on. Here in United States, in Japan, in India, in Czech Republic, in Chile, in Argentina, and more are joining us. Yes, we need to start as soon as possible if we didn't start it already. Awareness building. It's really, really very important in medical society, in medical congresses, in any kind of gathering where we have any professionals or any individuals with cleft lip and palate. We had very successful run for cleft prevention in Tokyo, in the Congress of Cleft Lip and Palate Foundation. We had over 70 individuals from different countries, from about, I believe, 40 countries, who actually attended that run. Of course, everybody learned that cleft prevention exists, it is possible, and will pass that information to their community, their patient, and so on. Another, again, is posters and cards and any kind of materials, brochure and so on, which we can develop and again pass during our missions. We have English version, we have a Spanish version, we have version in Hindi and in Canada now, and will be continue more, and will be trying to spread the knowledge, to educate ourselves, our team members, and also our patients and families with clefting there. If you are interested in more information, please visit our website, Cleft Prevention org. You can also download the English brochure, Can We Prevent Cleft Lip and Palate, there. We will have soon also Spanish version there, and more others will follow. So, with my request for spreading more information, learn more, talk to your colleagues, consult your patients, consult those affected with cleft lip and palate and their families. I would like to thank you for your attention. I hope you learn a little bit. And if you would like to have more information, don't please hesitate to contact me in any of these emails. Thank you.